This is Emily Peters for Nursing Care of the Growing Family, Unit 6. This is Emily Peters, Nursing Care of the Growing Family, Unit 6, Theories. So, major goal of pediatric nursing is to improve the quality of health care for all children. So, what are some things that we can do? Health promotion, nutrition, dental care, immunizations. With nutrition, young children tend to establish eating habits during that first 2 or 3 years of life. So we need to make that a positive time when they're learning to eat and establish those routines. Dental care. Dental caries is one of the most common chronic diseases of childhood. So once again, dental caries. That's the germs and stuff. So establishing that good dental hygiene early on is also important. So child health problems. The American cultural tendency towards excessive intake of high caloric fatty foods contributes to obesity in children. Obesity and type 2 diabetes. Overweight kids doubled and overweight teens tripled between 1980 and 2000. I will have more statistics on this when we get to Unit 7. Some other childhood problems are injuries, violence, substance abuse, even mental health problems, and that affects approximately 1 out of 5 school-age children. And then you also have unintentional injuries such as those accidents. These are leading causes of death from the youngest ages and into the adolescent years. So, injuries are the leading cause of child death in the age of greater than 1 year. So, drowning is one of the leading causes of death. Children left unattended are unsafe, even in swallow water. What is it, like 2 inches of water or 1 inch of water a child can drown in? Next is burns, are among top 3 leading causes of death from injury in children aged 1 to 14. And then motor vehicle crashes is also common. So we have motor vehicle crashes, drowning, fires, burns, firearms, poisoning, falls, mechanical suffocation. So what kind of things can we do to help with these issues? So, here's some pictures of poisoning. This causes a huge number of injuries in children under the age of 4. Prescription drugs, as we know, should never be left where young children can reach them. So what are some things we can do? And then mechanical suffocation is the leading cause of death from injury in infants. Look at that. And a baby has a plastic bag. Why would somebody do that? But some other things I've seen is our blinds that we use in our bedrooms, and the babies, as they're starting to pull themselves up in their cribs, are wrapping those cords around their necks. So that's a cause of suffocation. So there are different things that we are able to do to help prevent some of these things. So, when we're taking care of peds patients, we need to look at tons of stuff. So, philosophy, look at all human experiences. We also need to use those objective and subjective data, our scientific knowledge that we're learning in school. And we need to have that caring relationship and have that relationship where we can connect not only with the patient but the parents. We need to make sure it's family-centered. The family is a very important role in that child's life, and so understanding that family dynamic is very important. And including those families is also very important in those pediatric patients' care. We don't just deal with the needs of that child, we have to deal with the needs of the family in a whole. So we'll go into a little bit more detail and discuss this one in class too. So Why don't you guys think of what atraumatic care is to you, and let's kind of come up with some ideas that we can help prevent that or minimize separation, promote self-control, prevent and minimize bodily injury pain. So looking at what a therapeutic relationship, what is family advocacy and caring, health teaching, support and counseling, coordination and collaboration with everybody from the healthcare team to the family, those ethics. What is research and how does research help us? Also, when we're looking at providing atraumatic care to these patients, we have to look at therapeutic communication. This type of communication is goal-directed, focused, and purposeful. Then we can use therapeutic play. Therapeutic play provides emotional outlet or coping devices. And then child education. So we're not only going to just educate the child, but we're going to educate the parents too. A lot of people forget about educating that child and just focus on the parents. So child education, we need to help that child understand the reason for their hospitalization and procedures. And that's going to be tricky. So we need to understand the growth and development of that child and gear that teaching to where they are developmentally. So preventing and minimizing those physical stressors. Utilizing a child life specialist. These are specially trained individuals who provide programs to prepare children for hospitalization and painful procedures. They help minimize the physical distress during procedures. They can use positions that are comfortable for the child, such as therapeutic hugging and types of distraction methods. So what are some distraction methods? We'll discuss this in class more. Focus on that family-centered care. So we're going to respect for the child and the family, recognizing the effects of cultural, racial, ethical, and socioeconomic diversity on the family's healthcare experience. So we need to identify the family's strengths. We need to be able to support the family's choices related to the child's healthcare, which can be tricky depending on what some of those thoughts are. Be flexible, honest, give unbiased information. We need to assist with emotional and other support for the child and family. We need to collaborate with that family and empower them to take care of that child, because they are, especially if it's these long-term illnesses, they are going to have to learn how to take care of that child, and we are going to make sure they are the experts. We want to promote positive outcomes using that family-centered care. So decrease anxiety, decreasing recovery times when we can have those positive outcomes and use that family-centered care. We can increase families' confidence. Having that good communication between the healthcare team and the family. This all can contribute to lower healthcare costs. And then also providing a sense of control. So how do we do that? So provide effective communication and teaching, finding that balance between neutral and effective communication, the use of those verbal and nonverbals. Techniques, learning to hone in and develop good techniques when communicating with that child. And then helping that family obtain those resources and information they need. Okay, so our book talks about a lot of different major theories related to family. We have the family systems theory. This is a family-centered care theory. They view family as one unit, a system that continually interacts with its members and the environment, and it focuses on interaction. So family is one system within a layer of other systems. There's set boundaries, which, as we know, is an imaginary line that exists between family and the environment. So, for example, the idea that asking for help is okay versus people that view asking for help as a threat. A change in one family member affects or changes all of their members. So, for example, since we're in pediatrics, one child is ill, then they think of a ripple effect and how it affects the whole family. So they focus on what is occurring now and how to change that pattern. So what do? We assess the family's ability to accept new ideas, their ability to accept new information, resources, and opportunities. We need to help them plan strategies to adapt to these changes. We as nurses can intervene to help family prepare for and cope with the changes. This helps present with excellent opportunities for anticipatory guidance. There's also the developmental stages of the family life cycle. These are all on page 32. This is a series of tasks the families must master at different stages. So developmental tasks of the family thought throughout the lifespan. So families change over time. They're faced with certain developmental tasks in each stage. So you go from being a single adult to marriage. So in marriage we have a new couple identity, new relationship, and then you have those extended family members. Then you become a family with young children. So then they're learning the new family parent roles, and they need to help integrate that into a family. And then learning to socialize those kids, and then helping those kids adjust to separation. And then you have to throw in peers, and then the parents are adjusting to that peer influence. And then you segue into parents or families with teenagers, where those teenagers are having that increased autonomy. Parents at this time can also be dealing with midlife marital issues, to career issues, and things like that. Families are launching centers, so parents and young adults. Then they're establishing independent identities, the college life, that separation that is going on from being a child, being connected solely by your parents, and now being all out on your own, and the family and the parents dealing with those children having to become independent. And then we go into families in later life, where those parents are reinvesting in their couple identity and their in-laws. And then there's grandkids. So you have all these other dynamics. So their children are starting to have that new marriage and those extended family members. And then all the new children being involved. So the parents are starting to retire. They're starting to prepare for death. And then their children are starting to take care of the parents. Okay? So as a nurse, we need to provide anticipatory guidance and to help prepare family members for each transition and each stage that they're going to deal with. So developmental theories. I'm really hoping these are all reviewed for you guys from developmental psych. So we have Erickson's. So definitely, if you're not familiar with these, I want you to go back and review these. These are very important. So we have trust versus mistrust, autonomy versus shame and doubt, initiative versus guilt, industry versus inferiority, identity versus role confusion. So trust versus mistrust is infancy. Autonomy versus shame and doubt is 1 to 3 year olds. And this is when they're starting to increase that control of their bodies, imitate. Okay. Initiative versus guilt is those 3 to 6 year olds, so they're increasing their imagination. Industry versus inferiority is 7 year olds to the teenage years. And then identity versus role confusion is when we're getting into like those teenagers going into that adulthood. Some more developmental theories that I want you to get familiar with is Freud, your id, your ego, and your super ego. So your id is that unconscious mind. The ego is the conscious mind. So reality. Superego is that conscious and that moral part. Remember that Freud also discusses that psychosexual areas. So sensual pleasure, oral stage is that under 1 year, anal stage is 1 to 3 years, phallic stage is 3 to 6, latency is 6 to 12, and that genital stage is 12 and up. Other developmental theories that I'm hoping you're familiar with is involving cognitive development, so Piaget's. So review Piaget's intelligence. Intelligence increases the ability to adapt to the environment. That increases the probability of survival, therefore helping maintain that equilibrium. So you have sensorimotor, which is less than 2 years of age. You have that object permanence, reflex to imitate. Then you have preoperational, which is those 2-year-olds to 7-year-olds. They're egocentric. Their inability to put self into another place. You have concrete operations, which are your 7 to 11-year-olds. They have increased logic and coherency. And then you have the formal operations, which is the 11 to 15-year-olds, and they learn to adapt and become flexible. Then you have moral development, which is Kohlberg. You have the pre-conventional, that's good versus bad. Conventional, conformity and loyalty or approval. And post-conventional is that learning that correct behavior. And then families. We have nuclear families, extended families, binuclear families, single parent, reconstituted or blended, and homosexual. So we'll discuss these and break these down in class. So if you're not sure what these are, make yourself some notes. This is an example of an extended family. You have at least one parent, one or more kids, and one or more members other than the parent or sibling. So example, in this picture, you have a grandparent that is involved. This is an example of possibility of a single parent, which is this top picture of the mom and the child. Then you could have binuclear. So you have like that after divorce, you have biological kids and 2 nuclear households. You may have that co-parenting that's going on. This bottom picture could be an example of a reconstituted or a blended family, where there could be a step parent or step siblings, half siblings, whatever the situation may be. And then you could have those homosexual relationships and parents. Another dynamic we need to be aware of are divorced families. We discussed single parents briefly. Those blended families, adopted families, foster care families. What could this all mean to that child's health, and what dynamics do we have to deal with? With divorced families, we anticipate that most of those problems will occur within a year. Not unusual for those kids to have social, emotional, and or academic issues, maybe even sleeping difficulties. These are to be expected. The single parent, that mom or dad, may be overwhelmed, may need extra support, communication issues, and then you throw in blended families, the jealousy, competition, rivalry. I don't have to listen to you because you're not my biological mom or dad or whatever the situation may be. Adopted family and foster care families have their own issues. We can kind of in class we'll make up a list of some of those things as well. Parenting styles also makes a difference on how kids are reared and how this could affect their health care. So we have the authoritarian type of families. This is like any behavior that's outside of those family rules, you'll get some form of punishment. Authoritative, it's kind of like we show some respect for the kids' opinions. So the rules may be a joint type of decision. However, the parents are still somewhat in control. Permissive, has more negative than positive effects. This is when basically the parents somewhat allow those kids to be in control of the punishments or what goes on in the house. And then you have rejecting, neglecting. This is like a cold demeanor. They're uninterested in meeting those child's needs. It has huge negative effects. So these discipline strategies can cause all sorts of different things. We can have positive reinforcement, natural consequences. We could have fear that is developed from some of these discipline strategies. We'll discuss in class how some of these things are effective, the positives and the negatives, and I'll try to show some examples of things I've seen and how this could affect the care that we're able to do in the hospital. So, major components of society that influence child's health. So, social roles. So, in some cultures, the male is dominant. So how does that affect child's health? There's multiple social roles, and we'll discuss that in class also. Socioeconomic status. So where are we at in the society itself by our finances? How can media influence our health? Fad diets to natural remedies versus scientific remedies versus how people view weight, those types of issues. Then we need to look at cultural groups, and we have to remember not to stereotype, and we need to remember why these kind of things are important, because we need to make sure we understand how different types of cultures react to different types of illnesses, such as pain, to how involved the family needs to be, and who is in charge of certain types of healthcare. So we need to look at different customs, characteristics, language barriers, family structures. So, for instance, is that male the dominance and the one that's going to make all the decisions? To some ethnical groups or cultures, the grandparents help raise the children for the first few years of life to allow that mother to heal after giving birth. The types of food they eat, how they their healthcare practices differ from what we are used to doing. So this will be something we'll discuss in class. So describing the role of a nurse and helping deal with these different cultures and ethnicities. So self-esteem and culture. The child's sense of self-esteem is influenced by his or her culture. This may also be related to accomplishments of the entire family or community. The child's sense of control may come from those feelings of worth within the community. Poverty, homelessness, migrant farm worker families, so subcultural influences, ethnicity. I'm sure there's many others. Can you come up with some for class? Many kids grow up in these blends of cultures and subcultures. So, for instance, we could have somebody that is German, but also has some Irish tendencies, and they're blending those two cultures together and how they do their day-to-day life. how does immigrant children, and how does that affect their health? Religion, the use of schools, our community, peers. Nurses have a responsibility to continually develop cultural competence. Those physical characteristics and health problems can be related to any ethnicity. And then we got to look at children living in poverty suffer greater physical and mental health problems than those that are not in poverty. So how does all of this affect the nurse and her role? The use of effective communication, that awareness of relationship among family members. We need to become sensitive to our body and nonverbal languages, our verbal language, what we do that is, like, for instance, shaking of hands and things that we are used to doing. How could that be seen as a negative, or could affect how somebody interprets us? Violence, school violence and bullying, domestic violence, suicide, violent crimes. The longer these children are exposed to violence, and the younger the child is, the more serious the problems seem. So we need to look at all those dynamics as well. Media. Okay, we're going to discuss this, or we may have discussed it in our earlier conversation. Excessive caloric intake, activity, underage drinking, violence, behavior. How much is a positive amount of screen time? How much is not? Can this lead to obesity, poor cognitive skills, irregular sleep patterns, poor school performance? Look at all technology is so easy in our hands. Is this going to influence healthcare? Or what do we need to do to change it to make it a positive thing versus a negative thing? What kind of changes do we need to do? Well, so I want you to, if you haven't already done this, I want you each to observe family and their interactions with each other. What types of discipline were used? How did the child respond to discipline action? Think about things you may have seen in your own house. How did your aunt and uncle discipline their children differently than your parents, etc.? If you want to, this could be something to think about as well. Interviewing a child of divorced parents, or maybe you were a child of divorced parents. What were your feelings? How did that affect your ability to cope with your schoolwork? And kind of see how you coped and what different strategies you used. What strategies were positive and what strategies could have been negative. We'll go over this in class. Same with this one.